We are currently the global pandemic, which is the coronavirus. Is destroying businesses, individuals, organizations, and all of that. Today, we're in Lagos, Nigeria, where we have the best in our book. Our guest in our program is the US trained medical practitioner with over 5 years experience as a consultant physician in international operations. He founded the first state diagnostic center, the National Medical Association, and Reddington Cardiovascular Association. For 10 years, he was the chair of the Division of Cardiology and director of the Interventional Cardiovascular Laboratory at the St. Francis Hospital in Reddington, as well as a dominant program leader in the international cardiology and the Tristate Healthcare System, both in the United States level. He has extensive medical leadership experience in the United States of America and Africa, and has led many successful and highly impactful medical missions in Africa, in South Africa, and in Canada. He currently chairs the Division of Cardiology at the Benjamin Carson School of Medicine, Bangkok University. He is currently the president and CEO of Tristate Healthcare System, the vice president of Healthcare System of Edu Care. So our guest today is a visiting consultant at Reddington Hospital here in Lagos, Nigeria. His name is Professor Kamar, Tayo Adeleke.
Thank you very much for having me.
Well, we are currently having the coronavirus issue. What can you say? I mean, from the layman understanding, people are watching all the time. And some are having business. So, for example, people have an Android phone in the browser and see what this coronavirus is. And we keep hearing coronavirus, coronavirus. What is coronavirus?
Thank you very much for having me. And again, the coronavirus is the group of class of virus. And as you know, virus is in an individual very small organism that you cannot see with the naked eye. Viruses, there are so many kind of viruses. If you look at the common one, it's usually called rhinovirus. Rhinovirus is the one that causes common cold. You see it a lot of children, they say that they have virus. So these organisms, they are virus and they are different from, another kind of organism we call bacteria. The bacteria is the one that, people have, when they say they have to take antibiotics. So you can see, when you say antibiotics, it's antibacterial. So some people, they will have the runny nose, they have cold, they have cough, we call it catarrh here, but just well because of virus. You cannot see it. So this kind of virus that is now they are taking us, it's called coronavirus. There are some of us or some of you may even hear about flu virus, which is very endemic and pandemic in those days, some something years ago, that killed so many people. So the same thing now, this virus, you cannot see it, and apparently it started, in China. That was the first place where they found out, that the virus was eating people, before they actually know what kind of virus it is. So it was through the WHO and the nomenclature that they finally call it, COVID-19, which is a kind of a virus. And this virus is, it affects every single organ, but notably it affects the respiratory. Once you get into your respiratory tract, it can go into the lungs, and then it can cause so many things. It can cause pneumonia, blah, blah, blah. So it's very unfortunate because There is no cure for it. Once it hits you, the only thing we can do is to really make sure we give the supportive care, because people gradually get into respiratory problem and then they finally die of respiratory arrest.
All right, sir. Now, how did we get into this? I mean, as Africa, I mean, we we had an index case, the first case from an Italian man who came into the country, and from there we have a community transmission. I mean, now we have about 12,000 cases at home. I mean, what can the government do to ensure that this, comes down?
Well, I think number one, African have been blessed. And I don't know why. When I came to Nigeria, I see so many churches, so many mosques, all our previous industries are now turned to the. I said, why do we need all these churches? Why do we need all these mosques? I think that is probably, this is the answer. That God mysteriously is just really helping us. The virus goes everywhere. Wherever there's an air, virus will go. Okay? The interesting thing is that the whole world is global now. So people travel from China, where the index case was started, and then they went to Europe, they went to America. American, will come to Africa, and from Europe they come to Africa. And once you get it, once one get it, it's quite very easy to transmit it to the other people, through the, either the droplets, through the aerosol, now we know, even through the contact. See? So it's very easy. Look at us, the population of Lagos, 20 something million people. You see how easy it is to be able to even afflict everybody. To me, I'm so surprised that number one, the number of cases that we are having is so low compared to what you see in the Western world. There may be many reasons for that. People say maybe it's because of our immunity. I'm not quite sure. Because we have the African in the Western world, that have been afflicted and dying. Okay? Well, could it be because of the temperature? I have the feeling that maybe something about that. Because it's not really truly what we are doing. We don't even know the true incidence or the prevalence of the disease. Why? Because we are not doing as many testing as possible. Let me give you a coin. One of our colleagues, the guild, the director of, his guild of medical directors, apparently one company sent 14, this was just 2 weeks ago, 14 of their employees to go and have testing done. Okay, before they come back to work. 10 out of 14 came back to be positive. That is about 71, 72%. And they are asymptomatic. A 46-year-old came here that I saw, that couldn't breathe, no fever, nothing, no cough, no runny nose. And then when I saw him, his blood pressure was like about, 190. So we thought maybe that was the case, right? The reason. So we did the ultrasound of the heart was fine. We got the blood pressure down to 113. And then I told him to just walk in. They walked him, and guess what? He was still short of breath. And I said, this is COVID-19. We got the CAT scan, it was classic. Okay? Within 3 hours, this guy that was not requiring oxygen, now requiring 3 liters of oxygen. By midnight, he's already requiring 5 liters of oxygen. And he was sick, like a dog, almost for 10 days. And he survived. And yet, his wife, who also tested positive, didn't have any symptoms. Okay? So there are so many people. I think there's a blessing, either because of our youth, because the average age in Africa is very low. We know that the people who are very susceptible are those who are above the age of 65, those who have high blood pressure, those who have diabetes, those who have heart disease or lung disease. So the majority of our age, we're very young. So I think what the government can do, number one, as far as I'm concerned, is the testing. We need to do the testing. We need to do more testing to find out what is the incident. Okay? We have lost Africa as a whole. In terms of managing them, okay, it's going to be very, very difficult, because probably 90 or a little bit over 90% of people who have the disease will not have much symptoms, or may not even have any symptom at all. Okay, but maybe between less than 10% will be very sick. Those less than 10%, we don't have the capacity to take care of them. Only a few places, the population of 200, 1 million people. So the government need to really continue to do the testing. To me, I believe the social distance is still very important. We cannot, because the closer you are, the high likelihood you are going to get that person infected.
Okay, Prof, let me ask you this. I mean, we have over 12,000 confirmed cases in Nigeria. And when you look at the other part, who are being discharged, day in, day out. I mean, and they said there's no cure. What is the medical practitioner using to, that's what I'm trying to say.
Yeah, so the medical practitioner, when the patient that have symptoms come in, what are the symptoms they're going to have? Difficulty breathing. Okay? In fact, most of the time that's what they are going to have. Some people may have compounding secondary bacterial infection. So our job is to, number one, make sure that we are able to give them the oxygenation that they need. Make sure that we are able to give them the nutrition that they need. Make sure that we are able to hydrate them, because during those times, they can become hydrated. Okay, hydrate them and give them all supportive care that they may need, right? The the treatment of the, difficulty breathing may range from just giving the oxygen. You and I now, we are breathing oxygen. The oxygen in the air is about 21% that we are breathing now. So those people will require more and more and more. So we have to have those storage of oxygen that we can give them. Fortunately, some of them may not require more than that. Okay? And if they require more than that, we have to give. And that is going to be to support them with what they call, the another mask. Okay, that deliver oxygen at a higher concentration. Now, respirator, is something that at the end, and some of those people, once they get into that one, majority of them don't even survive it. Okay? And then if there's any secondary bacterial infection, the doctors are going to know, the healthcare guys, they're going to know, and they're going to have to give antibiotics. Remember I told you that's the bacteria. So people who have virus can have secondary bacteria, and then you have to really be able to culture them, make sure that you identify those bacteria.
Okay, but how come after all the analysis you did now, these same people who were positive will be tested negative, and there is no doctor?
Yes.
Is it after all the antibacterial and other drugs that we give them, the nutrition, will the virus now disappear? So how does it happen? How do you correlate?
That's a very, very good question you asked. God Almighty is the doctor of the doctors. Okay? So anytime you are affected with or contact with any infection, God already protected you. And the protection starts from the skin. If you go and scan our skin, okay, you will see, or culturally, you will see so many bacteria, viruses sitting there, but they could not penetrate. Okay? That is the first defense mechanism that we have. Right? That's why they say cover your nose, cover your mouth. So all those places you can cover. Once the either infection, either virus or bacteria get into your system, then your body now would develop what they call the antibody. The antibody, I'm sure you've heard about lymph glands. The lymph glands are the organs or the glands, glands that secrete this antibody. The antibody will now go against that whatever infection you have. Okay? And the people who are able to mount this, they're like military. They mount against this virus or the bacteria. Once they overcome the virus and bacteria, then the bacteria will succumb. Okay? And then the antibody now going to persist. And that is now, those are the people who already survive. It's almost like you go to the military zone. You have all the weapons and everything. You kill your enemy, and then after that one you come back home. Okay, so now you are cured, and that infection will not come back. I have a different feeling about COVID-19 though, in terms of recurrence of it. But that is the reason why. So by natural selection, you are your own physician, you are your own doctor, you are the own who protect yourself against that infection. Now, everything else that we give in terms of virus, really truly they are just supportive care. The medication, there's some of the virus that you actually can use, medication they call antivirus, Tamiflu, but typically you have to give them within like 24, 48 hours that they complete that one. So, but most of the time, virus don't have treatment. You are the one who cured yourself, from developing antibody against the virus.
All right, sir. You are a trained physician all the way from the United States of America, and the information we're getting is that the African Americans are the most vulnerable. Why is that? Let's go a little from Africa. Why is it so?
Yes. So, when you look at the susceptibility to infection, the susceptibility to infection actually, as far as I'm concerned, start with your preparation. The preparation starts from, the time that the mother got pregnant. Okay? The nutrition that the mother have, the kind of the care that the mother have is going to affect that baby. Okay? In building the immunity. So the mother that did not have very good nutrition, the baby is going to have very poor outcome. Okay? So now, also too, if you look at the size of the placenta, okay, which correlates with the care that the mother has, okay, also correlates with the incidence of diseases. In other words, the mother who have a small placenta, those kids have been shown to actually have so many diseases. That includes high blood pressure, that includes diabetes, small for gestation, small placenta. Because the placenta is the source of nutrition for the baby. So, and that's the reason why, if we really want to affect, the immunity of all the citizens, you have to start from prenatal. That is one. Then, when the baby is born, right? The good thing that we have again is that we see that we tell mother to breastfeed. Abi? The breastfeeding, the first breast milk that come out, we call it colostrum, is have been shown to have a lot of antibodies, okay, that you give to the baby. That also protect the baby. That's why we said they must breastfeed the baby for about 6 months. Now, if the mother does not have good nutrition, okay, and she herself is not in physical fit, how can she pass good antibody to the baby? You see what I'm talking about? So that is it. Then the next thing is that, okay, the baby is born now. There's something we call preventive care. You must give immunization. Okay? And we know that people who get immunization, they are giving them attenuated, bacteria or viruses or whatever, which now baby is now going to develop his own antibody against, so that that baby will not succumb to that infection.
All right, Prof. Now, you said something about having a small placenta. The baby comes with a small placenta. Such baby is vulnerable to have diseases. Is there anything the physicians, so to say, can do to increase the placenta? Is there the kind of treatment or something?
Right. So I think it's just not the physician. It's both the parent or the mother and the physician. That is why it's so important to go for prenatal care. Because prenatal care now, they're going to look at the nutrition. They're going to look at, what kind of vitamins they should take as a supplement, the food and everything, and whether or not mom already got immunization. But the placenta size has to do with, the kind of food, the kind of nutrition that the mother have, yeah.
All right, viewers, we are here with our guest, Professor Tayo Adeleke, a visiting consultant at the Reddington Hospital here in Lagos. We want to give you an opportunity to reach out to us. You can send your WhatsApp messages to our guest here who will answer all the questions. The number to send your WhatsApp messages is 081 388 233 25. For those of you watching us on Facebook, you can send a comment on Facebook and also on YouTube. Prof, now we are going to talk open surgery. That is one of the most difficult surgery. I'm not a medical politician, but I think I've heard little about some of those things. I mean, it takes a lot of process. Tell us about that surgery that you carried out successfully.
Thank you very much. The gentleman that we did is 64 years old. 64 years old who just passed out. When he passed out, he came to us, and then we found out that the electrical system in his heart was not working well. So, which means now that he needs what they call pacemaker. So we then said that why did the electrical system fail? We found out that it's because he had some kind of, because he told me he had chest pain. So we went and did another procedure to find out if he had any blockages of the arteries. And then we got that all the three blood vessels that supply the heart were all blocked by 99% each. So we now know that the blockage of the artery was what caused him to pass out. Okay, that causes the electrical problem. In addition to that, you also have renal failure, kidney failure. So we have to deal with a lot of issues. But the most important thing, number one, is that you have to go and take care of the problem, which is the blockage of the arteries. So we have to now do what they call the bypass. And what is the bypass? So you have a blood vessel that is coming down. That blood vessel have 99% blockage right here. So now you have to now, because that's a blocked road, right? You have to now have a bypass, get another blood vessel from somewhere in the body, attach it to where it's good, and bypass the area that is blocked and go back, to it's almost like connecting a different route. So to do that is quite very complex. And number one is that you have to put them on the medications, to stop the heart. Number two is that you have to put them on life support. And once you do that and the heart stops, we have what they call the heart lung machine. You stop the heart completely. And then once you stop the heart, you already open the chest, right? And then you expose the heart out. Okay, this guy too also has to have a valve replaced. So you have to open the heart again. So, and once you do all those three bypasses we talk about, then we repair the valve. And then after that now, you close the heart. You suture the heart back. Then you close the chest. And then once you finish that, then you now restore the heart beating, which now you wake up the heart, back again. It's kind of very fascinating. It's almost like playing God, but most of the time, because that is what we do for living, it's quite very straightforward. And in spite of the complexity, thank God, that you have all the support, that you needed. You have all the equipment that you needed at Reddington, so you were able to do it, successfully. Yeah.
All right. Before the COVID-19, people traveled to where you were trained in the United States of America, UK, and other countries. Medical tourism. They don't believe that Nigeria does not have the facility. Should I say that? Maybe our health sector is on the downtrend. So what is your advice for those who could go abroad? The issue. What is your advice? After we have Reddington and other hospitals in Nigeria that have really good facilities what can you say?
It is a shame because I think I always said it. As far as I'm concerned, I've never seen any race or any society that is smarter than Nigeria. It doesn't matter where you go in the world that you will not see Nigerians in the high end. Okay? We are naturally, blessed by the smart people. Okay? And our program used to be one of the best in the world. UCH used to be like one of the top 5 in the Commonwealth countries in those days. So things haven't really changed. What have changed is the priority. And I think the COVID-19 is a blessing in disguise. I tell you, because I always tell all my rich people, all my friends, there's something I call 60 minutes golden rule. That what is going to kill you will kill you within 60 minutes. I don't care how fast your supersonic jet is. Before you cross the big pond, you are dead. So as long as you're a Nigerian, you live in Nigeria for 6 months out of the year or whatever, even 3 months, there's a chance that when you are sick, you're going to be here. And that is the lesson that we learn from COVID-19. In fact, they didn't even, they have their jets, they have everything, but they are packed. Nobody could get out. So we're all in the same boat now. I believe truly that Nigeria is going to change from the healthcare. One is that we need the facility at Reddington, Babcock, Afro Biological University, and all the other institutions that have, this kind of facility, first class facility. And then you have Nigerians that can do it. Nigerians actually want to come back home. Yeah. I call it the reverse gain, of the brain, that we have lost for so many years. So all we need to do now is to replicate what we have. We don't have to reinvent the wheel. The wheel has been perfected. Build all these hospitals like Reddington, like Babcock, like Aguad, and every single center. And there's no reason why anybody should leave Kano to come to Lagos. There's no, and vice versa. Okay, every part of Nigeria is the health is wealth. It's the wealth of a nation. So I believe we can do it. I think it's going to change. And also too, from an economic standpoint of view, we don't have the foreign exchange. We can make it a tourist center. What is it? In fact, it's already shown. Yesterday at 3 o'clock, 2:30, I got a call, okay, from Tennessee, right? A gentleman left Togo to come all the way to Nigeria. They arrived here in Nigeria yesterday, and then they called me, and I came in to meet the patient here, 44 years old, 46 years old, who had the same thing, rupture all the aorta. Is in the operating room table right now. So now that is neighboring country. They already know now that we did something at Reddington. So that is reverse medical tourism. Okay? I mean, Africa spent about what, $4 billion in 2017, I believe, for medical tourism. $2 billion of that came from Nigeria. Can you imagine what that is going to do to our economy? The foreign exchange also is something that we don't have. And it's going to also create jobs, because when we open the hospital, you're going to have people that are going to do pharmacy. You're going to have people that are going to make equipment. Those who are going to make syringes. Those that are going to sailing. And then it's expanding the economy. So I believe the COVID-19 is a blessing in disguise. For Nigeria. And I see that it's going to change. I see the government is already doing that now. To really, encourage those people who have the skill, the institutions that have the capacity to help them, really build. If we have 20 Reddington in Lagos, we still don't have enough.
All right, sir. Before I ask you the next question about the government investment in the sector, viewers, you can send your messages to the number in your call area. The number is 081 388 233 25. For those that are watching us across board, across Nigeria, the USA, to Ghana, to Zambia, across Africa and the Western world, you can apply the code +234 81 388 233 25. That is a number to send your messages. The Prof is in the house to answer all your questions. All right. In the government doing enough in terms of investment, when you look at the budget, the total budget of the federation, what they have for the health sector is nothing, right? It's like what they have for education. What is your advice for that?
So I think there's no way the private can do this without the help from the government. The government have to create what they call the enabling environment. Take an example. I came from the US to come and establish Tristate. That is the name of my practice in America. Okay? Now, and when we got here, I wanted to do it. I ran out of money, and then I had to go and borrow money because we wanted to build the first program at Babcock University. That program cost us 1.9 billion naira. Okay, it's just only one operating room theater, one, cath lab, the CSSD, and 9 intensive care unit. That's it. 1.9 billion naira. When we went and borrowed the money, the bank started with 60% interest rate. They gave us 3 years, I think with 6 months moratorium. By the time we actually get to the second year, the interest rate already gone to 26%. So that is the business killer. It is impossible. I mean, thank God to Babcock, that they were able to rescue Tristate. Okay, otherwise that program would have died. Now think about it. Now with 1.9 billion naira, so we have done now close to about 400 open heart surgeries. Okay, yes, sir. Okay, and we have done the youngest we have done is about 2 weeks old.
All successful?
Well, I'm going to go to that. So the oldest we have done is about 86-year-old. So when you talk of successful, yes, actually I would say probably we are 99% success rate in terms of the surgery. But what we did is that we also look at the pediatrics and then the adults. We look at the complexity. There are certain diseases that are just low complex. They're all open heart surgery. There are some they call middle complex, and there's some they call high complex. They are high complex wherever you go in the world. The chance of those people, if you don't do anything, 50% they will die, within maybe 6 months, right? If you don't do anything. Even if you do something, they have almost like about 50% mortality rate, okay? Because if you don't do something, there's a gentleman that came from the north. He had been refused by practically everybody all over, 3 countries, including India, UK. He had 3 valves. His heart was very weak. And then they finally sent him to us. So we saw him, we put him on medication, and as we are weaning him off the medication, it decompensates, he just go back again, to respiratory failure. I finally called my team and said, listen, we have no choice but to take this guy to the operating room. Nobody wanted to touch him. They said, but he's likely to die. I said, if we don't do something, he will die anyway. But nobody want bad name. Guess what? Yeah. We took him to the, to the operating room table. We replaced 3 valves, okay? The guy actually had cardiac arrest on the table twice. We finished, we took him to the intensive care unit. On getting to the intensive care unit, he arrested again, cardiac arrest. We brought him back again to the operating room. He was in the hospital for 1 month. He is back now lecturing. That was 3 years ago. So if you look at those kind of people, our success rate is probably like about 99%, but people die before they leave the hospital, which is natural. When you look at the medium and the low risk, our success rate is about 99%, okay, in terms of those who go home. Now, when you look at in the cardiac cath lab, in the adult, the same thing. In the pediatric, the same thing. In the cath lab, our success rate is 100%, and mortality is 0%. So in other words, if you look at the amount of money that we have saved from people going on medical tourism, that is probably in the multi-million dollars as well. But more importantly is that there are so many people that couldn't afford it going abroad, but they took care of. So I think that is what we really need to do. The government need to really help the health sector in terms of the rate they are giving. You got to really support them. You can't be giving the interest rate that they are giving, and there are certain things that they need to also give so that they don't. I mean, I understand they are buying the ambulance. One hospital is buying the ambulance. They are bringing the ambulance to the country, and they are charging them as if it is just for the public vehicle. So you can't do that one. Yeah.
Okay. In the research, what you're saying is that the government needs to invest more on the health sector.
They have to, because currently they spend 4% of our GDP. Okay? I mean, for God's sake, cry out loud. The healthcare in America, which is the largest economy in the world, is about 16% of the GDP. That's the largest economy. So, we need, ours is like, 0.6. So we need to really invest in it. They need to do more. They need to spend more on the healthcare. And the most important thing is that, the insurance is a way to really go. There's nobody who have a car, who got a license that do not have, car insurance. We need to really do that for the healthcare so that people cannot be doing this cash and carry. How many people can afford to pay 4 million naira? Right? But if you have the insurance, it's a risk pool. Then these people will not have to be paying the money, upfront. And I mean, they pay it upfront. They don't have to be having the cash, and then they don't have to die unnecessarily because someone have to pay for the program. It's not free. Yeah. Someone have to pay. If we are doing the way we are doing now, we continue to do it free, right? How are we going to get the money to make it sustainable? How are you going to run it? The equipment, lifetime of the equipment is about 10 years. So in 10 years, you have to buy all this equipment again.
Okay, Prof. We have some messages coming in now. I have a lot of questions to ask you, but first, let's take the messages that we have here. The first one is from Kingsley Wachibu. He said, my question is that despite the increase of COVID-19 in Nigeria, the government has taken steps to relax the restrictions and even planning to open airports, local and international, I think and even worship centers. Sir, do you think this is a good step in the right direction? This message is from Kingsley watching from Ogogoshmo.
Okay. Kingsley, thank you very much. That's a very good question. So I think we have been in lockdown now for about 3 months. So you have to look at two things. You have to look at the economy and the welfare of people. Now, you see that people, and we are in a situation whereby you eat what you kill. Okay, we don't have welfare system. So people are unable to go to earn living. They are becoming beggars on the street. And even the people who are able to give before couldn't afford to give because of the downside of the economy. Abi? So now that is a very important thing. So people have to go back to work. Now, to me, is that the right thing to do? Only I don't know the right thing. Because some people will tell you, I'm going to die of something. Either I die of hunger or I die of COVID. And you know what? I rather die of COVID-19. Because that's by chance. If you don't eat, you will die. If you have COVID-19, I already made it very clear that almost majority of people will survive it. So that is the problem. Now, I think, so the government is looking at it from the economic point of view. When do we open? Okay. The most important thing as far as I'm concerned is this. I think the whole world is telling us that you're on your own. That you're on your own. You're on your own because, when you relax, there's no question in my mind that the incidence of this disease is going to go up. We don't even know the incidence in Nigeria. We don't know the truth. So it's going to go up. And as they go up, the mortality is going to go high. It's going to increase. So I think it's going to be survival of the fittest. Okay? What I would tell my fellow Nigerians is this. Do your own part. Do your own part by, number one, making sure that you still try as much as possible to keep that social distance. Number two, make sure that you wear this mask as much as possible. Number three, you cannot wash or cleanse your hand enough. Okay? Anytime you go out and you come back to your house, make sure before you go into your house, you wash your hand. Okay? And then you wear the mask and then, change your clothes and then go inside. Do your own part, because my feeling is that the incidence is going to go up. But fortunately, God is on our side. Majority of people already contracted the COVID-19, they just don't know. Yeah.
Prof, I think we have a lot of messages here, but let's see how much we can take. This one is from Mr. James from Shagamu. He says, sir, what advice would you give to Nigerians who still think that there is no COVID-19 in this country? No, certainly we have people like that who still believe there is no COVID-19.
It's so funny. I actually saw on social media too. They said that it is wrong. COVID-19 is bacteria. I read some that it's no COVID-19. It's malaria. It's Ebola. Whatever. Well, I want to just plead to everybody. This is science. You can take it from me. There is COVID-19. It has been proven and proven and proven time and time again. So the COVID-19 is here. And COVID-19 to me, I think also is here to stay. I believe that the virus is very smart. Okay, we're going to see a different form of COVID-19 that's going to come. The only thing that will save us is when we have the vaccination. I believe vaccination is going to come because once we have vaccination, everybody will be vaccinated. I hope we can get enough. So when the COVID-19 vaccination comes, please go and get it.
Okay, I have questions on that vaccine and all of that, but let's take some messages. This one is from Shegun Adeleke from Ibadan. He said,
Okay.
I'm watching your program live. My question is, do face masks really protect people? Because so many doctors have come out to say there are different types of face masks. So which one will actually protect us?
So yes, face masks work, but also you are right. It depends on what kind of face mask you have. You know, this is the N95 that I'm wearing. That is the most appropriate one that protects you the most. Okay, because it's sealed and it protects. The surgical face mask that we wear also is the next one, next level. The clothing face mask that you see around, because of the way it is made, you don't know who's making what. Some of them, they are not that effective, but they are okay. As far as I'm concerned, face mask, any face mask is better than no face mask. The most important thing about face mask is this, is that you have to really know how to put it on. You also have to know how to take it out. Because the face mask you are using, okay, is actually to protect yourself. Really, truly. Yes, you are protecting other people in case you have, anything. But most likely you don't have. What you are trying to do is to protect yourself. Okay?
Even the Ankara face
Even
we have different
we have
kind of
different
face
kind of face
masks.
mask. Exactly. The key thing is that that face mask cannot be reused. If you use it, make sure that it's properly washed. Because the virus, if anybody sneezes, if anybody drop, you're going to drop on that face mask. That's why you have to know how to take it off, how to put it on. When you put it on, it's new. When you're taking it off, it's probably dirty. You have to make sure your hand does not get onto that face mask. Because once your hand got in your fingers, guess what you do? You put it in your nose, you put it in your mouth. That is how the virus gets to you. So the face mask is to protect you, and then to protect you in case you are coughing, sneezing, or even talking loud. You don't disseminate it. So the N95 is much better, but anyone is still better, than nothing.
Okay, this question from Facebook, from which this question is actually different from what we're discussing now with the COVID-19. I don't know whether maybe I should ask because he said, Sir, I've been married for 5 years and my wife and I have done all necessary tests and diagnoses, but we still don't know what
No, we can take it. We can take it.
you can go ahead.
Yes, I am very sorry to hear that. Eh, when it comes to people not having baby, there are so many reasons for it. It could be on the men and it could be on the female. Typically, on the female, it's because they may have, some kind of blockages of the fallopian tube. The way it goes is that the men produce the sperm, right? The sperm have to go through the vagina, and then the female is going to produce the egg. The egg comes through what they call the fallopian tube. They are both now going to meet, and when they meet, then they form all the zygote and everything that end up becoming baby. So it's either because the woman is not ovulating and producing the egg, right? Or it's because the egg have to go through the tube is blocked, or it's because something is wrong, with the uterus itself. People who have cystic disease or whatever, polio, ovarian disease. It can be. So that is on women. That's why you have to really go to the doctor to make sure that they do all the anatomic checkup. To make sure number one, you're ovulating. Number two, you are producing the right egg. Number three, there's no blockages in all those, factory. In terms of the men, it can be because of what they call, oligospasm, spermia, because you don't produce enough sperm. All right? And if you produce enough sperm, it can be because you have what they call the lazy sperm. Because the sperm have to swim to meet the egg. The egg is sitting in the fallopian, the sperm have to come and meet. So if the sperm is unable to swim to that, and you only need one, then of course, they're not going to, because the sperm have life expectancy too. Once you stay there for long, so the most important thing again is that you have to go to see, the fertility doctor. The man also too, they can change the sperm, make sure the sperm count is fine, make sure they don't have any infection, or make sure they don't have any anatomic derangement. If all those fail, there's still hope. People need some medication, we call it clomid, that you can give to stimulate the ovulation. And some people, at the end of the day, you can actually do the artificial insemination, whereby you take the sperm, you take the egg, and you do them in the lab, and you implant back. So, but there's so many hope, for couples. Yeah.
So Cosmos has hope for you. So we have a lot of questions, but sorry, we might not take all the questions that we have here. But I want to ask you this, the last question. I might have one or two to ask before we go. We got 5 minutes to go. Tell us a little bit about the Tri-State. What is Tri-State? Here, Tri-State in back country. What is Tri-State?
So, what brought me to Nigeria was medical mission. In 2013, I came with about 68 Americans to come and do medical mission for 2 weeks. That was my first time coming back to do medical mission. And 68 of us, we saw about 5,000 patients. And during that time, it was really, really incredible. And that's when I found out that the average life expectancy of Nigerians then was 46. And then I started researching what is the cause of it. It turned out to be cardiovascular, heart and stroke. Well, that is my area of expertise. I left Nigeria over 40 years ago to go to America after high school. So I figured out if I don't come back, God will ask me. So the name of my practice in America is called Tristate. And Tristate because I lived in Delaware. And it is within Delaware, New Jersey, and Pennsylvania. I went to school in Philadelphia. So it's called Tri-State area. So it's called Tri-State Cardiovascular Institute. That's the name of the practice, which means Pennsylvania, New Jersey, and Delaware. So when I first came to do the first intervention at UCH, they sent me a letter of agreement and they said, Professor Adeleke, Tri-State. So when I came to Nigeria, I just named it. And it actually works because Tri-State, Oyo, Ogun, Lagos, so it's still the same, yeah. So that's the name, how the name Tri-State came up.
Wow. We have been having a good time here with
Thank you very much. Yes.
Oh, wow. On Facebook, have some messages here. Cosmos, Prof. I've seen John. I've seen Tayo too. We'll look for this. Prof, I want to appreciate you.
Thank you very much. Thank you very much.
You really have such opportunities to speak with
Thank you.
Viewers, this is where we go to the content. Thank you so much for watching live. Today from the decks of Reddington Hospital here in Lagos, Nigeria.